Hannah McLeod. I'm a student at AUT University, and for the purposes of assessment for the intermediate life support paper, I'm to film a video OSCE on RSI Assistant. So we've been responded to a 40-year-old male who's had a witness fall from a roof approximately 6 metres onto concrete, landing primarily on his head. So we'll start the simulation now. Hello, sir, can you hear me? Just checking his airway. It's okay at the moment. Can you grab a set of vital signs for me? His breathing's pretty irregular, he's quite combative as well. Can you just tell me if he's got a good peripheral pulse? He's got a strong carotid?
Yes, peripheral.
Okay, alright. I might try and see if he tolerates an OPA at this point. Just managing his airway safety first. Put my goggles on. Right, measuring up my OPA. Cool, so he's tolerating that OPA really well. Not worried about gagging or anything like that. I can feel a bobby patch on the back of his head there, so we probably need to be looking at TBI management. So oxygenation is key. He's got poor breathing at the moment as well. Sitting at 10 litres of oxygen per minute at this point. And I'll pop this under his head to maximise airway management and neutral alignment. So I'm pretty happy with this airway at the moment. What are this gentleman's vital signs?
So we have a blood pressure of 160/90,
Yep.
a heart rate of 50, a respiratory rate of 12, BGL of 7.6, and a temperature of 37 degrees.
Okay, alright, so this is looking a lot like a traumatic brain injury, but can I just get you to do a quick blood sweat, quick secondary survey, see if we can find any other glaring issues. Okay. So for the purposes of this OSCE, this patient does have a TBI. The mechanism of injury is consistent with a traumatic brain injury. He's got a bobby patch at the back of his head. His vital signs are indicating Cushing's triad. So I'm just going to run through assessment of a GCS. Have you found anything on the secondary survey?
No,
okay. So can you open your eyes for me? Right, so eye openings score of 1. Verbal, he's moaning and groaning, so that's a 2, and he's showing extension, so that's a motor score of 2. So I've got a GCS of 5. So I've got a GCS of 5, so it's definitely less than 10. He's got poor breathing, and we're having to manage his airway as well. And he's got a severe traumatic brain injury. So we're looking at possibly RSI for this patient would be really good for him. So would you be able to call for RSI backup?
Yes.
And we'll continue to manage this man's airway and breathing at this point. So we haven't found anything on the secondary survey other than this bobby patch at the back of his head. So we'll manage him primarily for a TBI.
So backup's 10 minutes away. They've asked us to prepare for RSI.
Okay, alright. So before we prepare for RSI, I'd quite like to gain IV access and treat his combativeness with maybe some morphine. So if we can swap positions, if you can keep an eye on his breathing and oxygenation, and I'll gain IV access. If you can wear these glasses, that would be good as well, just in case he vomits and you have to turn him on the side or anything like that. So applying the tourniquet, venous tourniquet, I'll try and gain IV access in his ACF initially. So swabbing the site. Getting that nice and clean, getting my sharps container out as well. So I would be trying to get the biggest gauge needle in that I could in his ACF, but for the purposes of this OSCE and the mannequin, I'll do it with a 20 gauge needle. I've got my little plug ready as well. Also sharps out. Cool. It's advancing nicely. Releasing the tourniquet, pressure, sharps out at this point, straighten sharps container, attaching the lower plug. Thank you for that. Cool, so lower plug's attached. I'm just going to secure it with the tegaderm. Tegaderm in place, and I'll flush it just to check that we've got a patent line. I'll be looking at drawing up some morphine as well. To administer. So I'm looking at my flush, so I'll drug check this as well because it is something that I'm going to administer to the patient. So 0.9% sodium chloride 10 ml, expiry August 2018. Can you please drug check that for me?
Sodium chloride 0.9% expires August
0.9%, you said?
2010. 0.9%.
Yeah, cool, okay, alright. So I'll just flush it to make sure I've got a patent line there. Are we still happy with the airway and breathing?
Yes.
Yeah, still got good vital signs there.
Yes.
Alrighty, so for the purposes of this OSCE, I don't have access to controlled drugs, so I can't demonstrate the administration of morphine, but I will verbalise what I would do and how I would do it. So using a 10 milligram morphine sulfate in 1 ml ampule, I would draw that up into a 10 ml syringe and dilute with sodium chloride 0.9% to a total of 10 ml. This would give me a 1 milligram in 1 ml solution. I would label that with a sticker and the dilution. I would drug check the ampule with my crew partner, as well as the sodium chloride that I'm diluting it with. And then I would choose to administer, after looking for any medical adjuncts that indicate any sort of allergy, which in this patient there will be none. I would choose to administer initially 2 milligrams of intravenous morphine through this line to help with the combativeness that this patient is showing. It's important to reduce the combativeness because that will be contributing to hypertension and increase the intracranial pressure, which will cause secondary brain injury and be ultimately very damaging to this patient. So I'm pretty happy with the oxygenation and managing the combativeness at this point. So if we swap over, I'll get you to run me through the RSI checklist if that's okay. I'll just borrow those glasses again because I'm near as anyway. Yep. Cool. So talk me through it.
Right, attach nasal prongs without oxygen.
Cool, so attaching these nasal prongs.
Pre-oxygenate using a reservoir mask at 10 litres per minute or a manual ventilation bag at 10 to 15 litres per minute with PEEP set at a minimum of 5 centimetres of water.
Cool, so I'm happy with his airway and his oxygenation at this point just with a reservoir mask, so I've got it running at 10 litres per minute.
Attach ECG, NIBP and SpO2.
Yep, so NIBP, SpO2 and ECG leads are attached, so that's good. Yep.
Prepare capnography if this is available.
Cool, so I'll attach my capnography to the MRX and I'll have it there available for the ICP to attach to the tube or the LMA, whichever ends up inside the patient.
Position the monitor so that it can be seen, leaving space on the right side of the patient's head for intubation equipment.
Cool, so leaving space here. We do have an intubation roll here, so I'll place that on the right side for the ICP to use.
Gain IV access, preferably in 2 sites.
Cool, so I've got IV access on one side at this point. For the purposes of the length of this video, I won't demonstrate obtaining IV access in the second ACF, however, I will verbalise my intention to do that.
Prepare a running line of 0.9% sodium chloride.
Cool, so I've got a line here, 0.9% sodium chloride for intravenous infusion, expiry date August 2018. Can you please drug check that for me? Just verbalise the expiry date.
Expiry date August 2018.
Cool, happy with that. So I'll attach that to my patent IV line at this point. Cool, so I'm only going to be running this IV line slowly at this stage. This patient is slightly hypertensive and administering sodium chloride to patients with severe TBI for adults if they have, is really only indicated if their blood pressure is less than 120 millimetres of mercury. So for this patient, he has a systolic blood pressure of 160. So I will run this line very, very slowly, only to maintain the patency of the line and not for the purposes of fluid loading. I don't want to increase his systolic blood pressure any more than it already is, because that will cause secondary brain injury from hypotension and increased intracranial pressure.
Position the patient for optimal airway control. For example, consider placing a folded towel under the head.
Cool, so I've already placed a blanket underneath his head to align his airway.
Place an ETT holder with the strap undone under the patient's head.
Yep, that's there already.
Ensure suction is working and turn it off.
Suction is working, and I'm placing the yanker handle next to the patient's head.
Prepare a manual ventilation bag with the PEEP valve attached.
Also, I've got my BVM, I've got my PEEP attached, and I'm setting it in the initial stages to 5 centimetres of water, and I've got my bag mask attached as well, which will fit the size of the patient's face.
Obtain a set of vital signs.
Also, we've got the ECG on already, we've been monitoring his breathing, SpO2 is attached, and I'll just grab another blood pressure as well.
If possible, update the responding ICP with the patient's condition and vital signs.
Cool, so can I get you as my offsider to do that? So currently we've got an SpO2 of 94, we have a blood pressure of 160 on 90, we've got a heart rate of 50, and the temperature and the BGL that you got before, which are within normal ranges. His GCS is still 5 as well. Yeah.
Prepare the area. If the patient is not in an ambulance, clear the area so that there is access to both sides of the patient if possible.
So I'm removing any gear that's not immediately necessary for RSI. So cleaning up my IV roll, I've got my suction ready, everything else is required. And that's done. Cool. So we've completed the RSI checklist, which is really good. Now I just need to manage this patient for his TBI pending the arrival of the RSI endorsed ICP. So I will primarily be focusing on the airway and breathing and ensuring anything I can do to minimise hypoxia, hypo or hyperventilation, and hypertension. So all of these things contribute to secondary brain injury, and we want to try and minimise that. Like I said before, the running line required for the checklist is just running slowly to maintain the patency of the line. However, I'm not administering 1 litre of fluids to this patient because he's an adult and has a TBI, simply because his systolic blood pressure is still too high for that to be indicated. Oxygen is still being administered for this patient to prevent any hypoxic brain injury. So we also need to be thinking about what might happen if the intubation fails. Now we would be looking at going and using the failed intubation drill. So if, for example, the ICP cannot visualise the cords within 15 seconds or can't intubate within 30 seconds of laryngoscopy, we would be looking at removal of the tube and manually ventilating this patient with a bag valve mask and oxygen if required. The ICP may then choose to use a bougie to guide the retry of the intubation. They may choose to use a different blade, and we may be required to optimise head positioning and or apply anterior tracheal pressure to help with the visualisation of the cords. Providing that this intubation is successful, we would then move on to post-intubation management. However, if this is unsuccessful, the tube will be removed and we may be required to insert an LMA, an OPA, or an NPA as well, and ventilate that patient. If ventilation is still not able to be done well, the ICP may look at a cricothyroidotomy as well. We should be prepared to assist with that in any way we can. So here ends this video OSCE for RSI Assistant.